we're back. So, shown here is a nice little table with some of the major genetic susceptibility loci. If you have particular changes in some of these, even maybe one of these particular genes, it can lead to just massive IgE mediated allergic disease. So, we're not going to learn all of these for sure. And we're actually not going to learn any of these specifically from this table, but there are a few that we mentioned before, and so I reserve the right to call back to those. For example, let's just go through the categories and then I'll pick out some of the highlights. So there are going to be genetic factors. So if you have proteins that are involved in airway epithelial cells. Airway epithelia are both a thing that you're going to notice. So you're going to notice if they get an inflammatory response because your airways are going to get real small and it's going to be very hard to breathe. It's going to feel like asthma and not good at all. Also, your airways are a major site where allergens can come in. And so if you lose integrity of the epithelium at the airways, then it becomes easier for little pollen grains or whatever to work their way in. And those are just like very broad things that could happen. There is a profound mechanism involving many tiny parts behind each one of these things. And I'm sure they're all fascinating, but at the same time, we're not going to learn it in a undergraduate immunology course. But yeah, just anything that goes wrong. So, like if your epithelial barrier protein FLG is non-functional in some particular way, it can lead to a weak epithelial barrier. I mean, that part at least makes sense. Same thing if you have some of the antimicrobial peptides that are broken so they don't work the way they're supposed to, or they work in a way that they're not supposed to, for example. Okay, if you're talking about things inside CD4 cells. So remember, CD4 cells can go any of those four different directions, Th1, Th2, Th17/22, and T regulatory cell. And each one of those involves a very different transcriptional program. And so if there are problems with some of the transcription factors, you may not be able to make an efficient Th2 response or, T regulatory response, both of which could have very severe consequences on your ability to make an appropriate immune response. Look at some of these cytokines. So a few of these we already know. Interleukin 4, remember that one? Yeah, it's the one made by Th2 cells. And interleukin 10 is one that's made by T regulatory cells. Right. Yeah, you got this. Okay, cytokine receptors. My goodness, if making an inappropriate amount, quality, or quantity of interleukin 4 is a problem, and it can be, then why wouldn't making, some aberrant version that either oversignals or undersignals of the interleukin 4 receptor be bad? And of course, it is bad. Yeah, it can be just as bad. You've also got interleukin 6 receptor on here. Interleukin 6 is involved in the very early stages of an inflammatory response. People looked in the early days of COVID at putting in antibodies against interleukin 6 to stop that component, thinking that it's what was setting off all the rest of the problems that people were having. Turns out it actually wasn't effective, and there must be other mechanisms that are controlling that. But it was a good theory, and some smart people came up with it. It just didn't happen to work out. Fine. Pattern recognition receptors. Now you know about those, like your nods and your toll-like receptors, particularly TLR4. Yeah, you remember that one. Highly involved in antiviral responses. Those are going to be involved in whether, for example, some of these antigen-presenting cells will present or will just, sort of hang around, doing their, stay in place. If we get on here to genes with other functions, you'll see just a whole bunch of other things involved in signaling. So Notch is a big surface signaling pathway. Honestly, there's a story behind every one of these things. Got some kinases that are involved in the immune system, like CDK2, cyclin-dependent kinase, and a bunch of other stuff. So the human body is a complex machine, and like with any complex machine, if you know anything about car repair, call me. My car needs some repair, but yeah, you know that there are a lot of ways that the machine can fail, and it can be difficult to diagnose. Just you say, all right, the immune system has malfunctioned. This is an allergic response. What could have caused it? Any of these things and some things that are not on the list. So yeah, it's difficult untangling all these things. That's immunology. All right, let's mention the hygiene hypothesis. I think the hygiene hypothesis is pretty dumb, but yeah, it's in the book, and there are still some people that absolutely adhere to it with some reason. I'm being a little unfair here. So we mentioned atopic, which means an allergic reaction at some site other than the one where you get the actual antigen coming into contact with a mast cell or basophil with IgE on it. And so the idea was largely based on babies that are born with cesarean section, via cesarean section. There were some early studies that showed that they tended to have more problems with allergy later in life. And so the idea was that if you start out too clean somehow, then the body goes nuts. And it's something that I've heard from many people growing up. This is like common wisdom. Yeah, just, I don't know, old wives' tale. It's probably beyond that because there's a little bit of substance behind it. But this is it. Now, for the most part, it actually doesn't work out that way. And I think the areas that are covered by the hygiene hypothesis get smaller and smaller every year, basically. So it's mostly discredited now, but this was the idea behind it. And so the prediction was that you would get more atopic responses, which are going to be driven by something soluble like IgE in the bloodstream. So think where it says atopic, it means second sight, but really they're thinking IgE. You would get that if you were predisposed to making a lot of IgE. And the idea was that if you grew up in a more hygienic atmosphere, that somehow had fewer bacteria in it, or whatever, then it would lead to this. And since then, we've learned that the air has something like 10 to the 6 bacteria per cubic meter all the time, everywhere, in both a dump and in, the most sterile hotel room, or up in a weather balloon, a mile up in the air. It's still about the same. And an equal or greater number of viruses in that same amount of air. So you're basically running into potential allergens all the time from all sides, even as you sit there and breathe. So, yeah. All right. But moving past that nonsense. So what actually happens? Well, so I said that we get this mast cell activation and release of the granules, degranulation. That's fine. And so that can happen at multiple sites. So you can get mast cell activation in the gastrointestinal tract, which can lead to vomiting and nausea and diarrhea. Yeah, that's how it starts. It's going to start with basically an immune response. So, yay. Yeah, all that allergy stuff that's happening in your eyes, nose, and airways can be driven by mast cells, and they can lead to constriction of the airways, increased mucus secretion, swelling, wheezing, coughing, etc. And it will also potentially have an effect on the blood vessels, because you can get allergens into the bloodstream via various pathways. And once they are there, yeah, you can end up with increased permeability of the blood vessels, which can lead to edema, which can lead to weird things happening in your lymphatic system. And you can end up with hypotension. You can end up with all kinds of cells leaking out into the tissues, like we showed on the hepatitis slides. And yeah, essentially you'll get it makes it easier to get an immune response out of the bloodstream and into the tissues. But if it's happening because of an allergen and not because of an infection, then basically that's your immune system beating you up, yeah, for no good reason. All right. So, specifically, this table will show what mast cells do. Then the next table will show, I believe, what basophils do and eosinophils. And so they're going to have a lot of different things in those granules that they can release. And so among these things, you're going to have histamine, which is directly toxic to some parasites, but is also going to increase permeability to let more of those neutrophils out where they can beat on the parasites if they've got in there. You're going to have cytokine release. So mast cells very good at making interleukin 4, which is going to stimulate a massive antibody, Th2 type response. Yeah, we're going to try to clear out some sort of pathogens, just like I need some help, make me some antibodies. And sure enough, they will. You'll have prostaglandins, so these are going to be involved in pain, among other things, but also smooth muscle contraction. And so you have these muscles in your airways, and those can contract somewhat. And that can also narrow the airways, so it gets harder to breathe, which can be very bad. All right, and that's just for starters. So that's what mast cells can do for you. What about eosinophils and basophils? Why? Look at all the cool stuff they can do. So collagenase, it can remodel the extracellular matrix that's on the outside of cells, which is kind of neat. So a collagenase would break down collagen, but there are also pathways that lead to more extensive collagen production, where you clear off the thin layer and you put a big thick layer on there. That leads to long-term constriction of the airways. You're going to get cytokines, so transforming growth factors alpha and beta are going to be pro-inflammatory, as well as here are some inflammatory cytokines. And you're going to get things like platelet activating factors. So platelets are definitely involved in the immune response. They're not just for clotting. Yeah, there are quite a number of these things. They can have neurotoxic effects. They can be toxic to parasites. The neurotoxicity is generally going to be a side effect, an undesirable side effect. But yeah, there are situations where each of these things can work to your benefit. It's just that if you're setting off this powerful weaponry because of a little puff of pollen that's not going to hurt you anyway, then it can have serious consequences. And I think that's the key behind these two tables. A lot of serious consequences. So between these tables, I reserve the right to pull a question from one or both of these tables on some of the things that can cause be associated with the allergic response that can come from either mast cells or eosinophils / basophils. So there you go. Be warned. All right. So what's all this do? Like, well, you'll actually have a multi-layered response. So even at the same site, you can have like an immediate response, which is like a short, sharp swelling, for example, versus a late response, which is just a massive, wider swelling. And so here we can see here, this is measuring the basically the peak expiratory, like breathing out flow rate. And yeah, a decrease in that means inability to breathe. It gets hard to breathe, which is actually fairly terrible. And so you'll have an immediate constriction, and that's going to be like an asthma attack, acute asthma attack. But then, quite often, there are going to be other components. So this is the immediate degranulation, but then some of those factors take a while because they're going to call in other cells. They're going to cause a different and longer immune response. Think of all those interleukins. Think of all those cytokines and chemokines that are being dumped out there. Each of those calls to and affects various populations of cells from the immune system, and sorting all of those out is a ton of work, and a portion of that still needs to be done. Yeah, definitely. So you can get a late phase too, which is going to be all these sort of aftershocks, if you like, of the immune system. So showing some of these, if you have, now depending on the route that the allergen is coming in by, so let's say you get an allergen like from a rusty nail or something that is actually intravenous. Somehow you get the allergen directly into your bloodstream, that's fine. It can leak out of the capillaries, and there are mast cells that are going to be in the tissue side, but near the capillaries, and so they can then get activated via the bloodstream. And cells of the immune system, yeah, they have to be ready for activation from any side at any time, all the time. When that happens, what you're going to get is degranulation, which is going to lead to a sort of constriction of the blood vessel, and narrower things going to lead to faster flow. Yeah, so we're trying to cycle more messages and immune cells past the site. You can get subcutaneous, so you can get basically coming in through the skin via a break in the skin, or just somehow diffusing across the skin. And yeah, you know that it's happened, but you don't necessarily know how it happened. But if it happens, sure enough, there are mast cells waiting there, and they will also degranulate and do basically the same thing. They'll try to bring in some help to this site, because these mast cells, they're tissue embedded, and so their job is not to fight the entire, invasion by themselves. Their job is to be like a sentry or a scout. They're the lookouts, and if they see something bad is coming, then they are going to try to call for help. And vasoconstriction is one of the ways that they do that. They just are trying to drive increased traffic their way, like faster flow, like get all these blood cells past, give me some immune cells, because we need to do something here. Inhalation. So if you breathe in these little pollen grains or whatever they are, that can also set off mast cells. You'll have some of those in the airways if the pollen grain happens to manage to work its way through and actually find one. And you also have these muscle cells in your airways, and so it's going to lead to contraction of the muscle cells, degranulation of the mast cells, and it's going to lead to sort of a breakdown in the respiratory tract. Now, this is going to be helpful later because it's going to allow things like neutrophils and basophils and macrophages that come from the bloodstream. They're going to have access to actually get to the surface and try to clean up whatever the problem is, if there is a problem there. When it's a virus, this is a lifesaver. When it's pollen, this just makes you a little bit miserable. And lastly, let's say you ingest some of these allergens, like a little bit of harmless peanut protein that's not so harmless because you have a massive IgE response already. So if it binds, and in each of these cases it's binding to IgE that's on the surface of these mast cells, then it's going to set them off, and they're going to cause constriction in the gut, which can potentially lead to diarrhea. And we are also going to change blood flow down there, and yeah, in general, you will feel sick to your stomach or have various intestinal problems. That's the idea. So this is like a bad case. This is an airway, and so here you've got the cells. You've also got the ring of smooth muscle around this airway, and this is going to be just production of massive amounts of extracellular matrix, just like gunk that's blocking the air passage. And you can see there's only a tiny little bit where air could actually fit down there. That's going to feel really congested. This is congestion. Generally survivable, as bad as this looks, because you'll have other airways that are maybe not so occluded. But yeah, if all your airways were this blocked, there's no way you would live. You have to be on a mechanical ventilator, and even then, I think it's hit or miss. Yeah. And then once you get that that allergic response, you're going to get all these little dark cells. They're going to be coming out of the blood vessels and working their way toward the sites where the allergen was picked up. And over the long term, what you get is this. So these are from a particular kind of mouse. There's a protein called Tbet in mice, and Tbet is a transcription factor that they have to make that drives a Th1 response. So think natural killer cell type response, interferon gamma producing response. If you have Tbet, then whatever, they expose them to these allergens, and they essentially have normal airways because they're not making a strong antibody response, which is going to come from Th2. Yeah, they're making a Th1 response. If you knock out that, so they can't even make a Th1 response, and there's basically nothing there to slow down the rampant snowballing of a Th2 response, then you get stuff like this. So you get, I'm not sure if this is, I guess that's an airway, a little airway. But look at all these little purple dots around here. That's massive infiltration. And they're just destroying tissue. They're beating up epithelial cells around there. And that part of the lung is not going to be available for oxygen exchange for, it can take a month or two for this sort of scar tissue to heal in the lung. And sometimes it doesn't. Yeah, so. The other thing that can happen is massive airway remodeling. And so here we have just increased collagen, just like a big thick layer. It's like the cells are saying no more, and they're putting on some armor so that they stop getting beat up. But you can end up with sort of thickening and hardening of the airways, which in the long term just makes it harder to breathe. Yeah, so that's one of the long-term consequences of sort of progressive allergic reactions, progressive Th2 type reactions to nothing. So all these immune reactions, very useful in the right situation, but in the wrong situation, these things can and will kill you. Absolutely. Okay, food allergies, why not? So these are things that are considered to be risk factors. There are one or more studies behind each of these, but there isn't just like one thing that is associated with food allergies. Some people say it's introduction to solid food, and not just some people, there are actual studies, birth by C-section, etc. But yeah, honestly, I tick a lot of these boxes and don't have any known food allergies. And my next oldest brother, everything the same, except he has horrendous food allergies, or at least he did when he was younger. So yeah, same environment, same parents, same dinner every night. Wildly different responses potentially. So there you go. All right. All right, and we are getting, we are almost at the end. Yeah, we are very close to the end, which is good. So there are treatments for allergic disease. So you can put in, for example, steroids. Corticosteroids will actually cause destruction of some of the eosinophils. And so you'll knock out some of the cells that would be driving binding to IgE and causing responses. You can put in antibodies against IgE that will grab onto the IgEs and get them phagocytosed, basically, and destroyed. Yeah. And yeah, why not? It can work. But like all these antibody therapies, you'd be able to sort of clear them out, and then they'd build up over the course of, even a couple of days. And you'd have to do it again. And it would have to be intravenous for this to work. There are ways that people are thinking of, and more progress on some of these than others. So there are people that are playing around with Th2 activation, like should we turn it off at certain times, turn it on. There are very strong ways to do these things, but in general they tend to amount to like being a little bit too strong. And generally the knock on them is that there's not enough room for the body to make an appropriate response if you control it too heavily. Like, you don't know what the next thing you breathe in is going to be and what effect it's going to have on you. So yeah, but these could work. You could try to block CCR3 or interleukin 5, which are going to be on eosinophils. And so instead of just murdering your eosinophils with corticosteroids, you could just try to calm them down a little bit, basically make them less likely to be activated. Same thing, you could blockade the IgE receptor. You could flood little chemicals or little soluble IgEs that bind to nothing, and you could just try and block up all those Fc epsilon receptor 1s. Yeah, it can work. Okay, and that is actually the end. Yeah, good. Not just close to the end, it is the end. So thanks very much, and yeah, see you next time.